From the heartland of the United States and one of the leading children's medical centers in the world, welcome to the Children's Mercy Kansas City Pediatric Bioethics Webinar Series. We invite international leaders to discuss critical and controversial issues in bioethics. Now, from the Bioethics Conference Center on the Adele Hall campus, here's Dr. John Lantos.
Welcome back, everybody, to the last webinar of this academic year. We'll be back in the fall, but we have a great final webinar for this year with Larry Churchill from Vanderbilt, who I'll tell you more about in a minute. But first, a couple of announcements. This week in Kansas City, we're doing a conference on pharmacogenomics and personalized medicine in pediatrics. That's Thursday and Friday. So if you're in the area, want to learn more about personalized medicine and pharmacogenomics, you can still sign up for that. Go to our website and you do that. We're taking applications for our certificate program. We have a special program for nurses who want to become nurse leaders in bioethics. Look on our website to find out more about that. We have scholarships for students from low and middle income countries, so look that up as well. We're taking applications now, and spots are filling up fast. We also have a special feature with today's webinar. We are doing a Twitter chat at the same time as the webinar. If you have a tweet, an urgent tweet that you would like to post, go to hashtag #WhatWouldYouDoDoc and post that tweet, and we will be running those along the bottom of the screen as the webinar goes along. Speaker for today is Professor Larry Churchill, who's the Ann Geddes Stallman Professor of Medical Ethics and a Professor of Medicine and Philosophy and Religion at Vanderbilt University in Nashville, Tennessee. He's a prolific author and commentator in bioethics. He edited the Social Medicine Reader, which is now in its second edition, with a third edition coming out soon. He's written about health policy, about rationing, and his most recent book with David Schenk is Healers, Extraordinary Clinicians at Work. It came out from Oxford in 2011. He's a member of the National Academy of Sciences and a fellow of the Hastings Center, and he is going to talk to us today about, Doctor, if this were your child, what would you do? Thanks for coming to Kansas City.
Thank you. It's a pleasure to be here. I should say from the beginning that this is not a question on which I hold any expertise. I'm interested in this question because it seemed to me it was being asked many times by lots of different people, and it has a kind of recurrent publication history. So I thought maybe this would be a good one to discuss, and one in which I stand to learn probably as much or more than any of the participants do. I always feel that when you're giving a talk like this, there comes a point when the audience begins to think, when is this guy going to shut up so we can discuss this? So I've always tried to put a little indicator in my slide. So when you see the bird, you know I'm about 5 minutes away and the end is in sight. So this is the territory I'd like to cover with you today. I want to review some of the existing literature over the past roughly 20 years. I want to talk about the inevitable interpretive task and some pitfalls along the way. I want to talk then about the aims of medical recommendations and advising as I see it. And then finally, if time permits, some of the moral virtues that I think are embedded in responding to this particular question, what would you do, Doc, if this were your child? So these are some of the helpful distinctions and points I found from reviewing the literature. Bob Trug, who has written some of the best things, I think, in medical ethics, talks about the differences between advice based on medical facts and value-laden advice, an important distinction to keep in mind. He also talks about advice that is facilitative versus advice that is directive, with the idea that directive advice one ought to be very, very cautious about. Facilitation is the favored alternative here. Bill Ruddick and also Gutgesell, I may be mispronouncing that, have emphasized the potential differences which we all might be able to enumerate between a physician's values and the patient's values. And the whole idea of working in a pluralistic culture in which you can't be certain that the values that you hold, your personal values, would be consonant with the patient's or the patient's parents. Then Rebecca Mannix wrote a lovely piece 3 years ago in which she articulates an instance in her own life when, as a second-year resident, she was asked this question, answered very directly, and now is thinking about the fact that her life experience and her practice experience put her in a different place. And so she says, one thing to bear in mind is that the clinical and life experiences of the physician may weigh heavily into this. And she talks about the fact that she is now asking this question of an oncologist regarding her husband's pancreatic cancer. So putting yourself in different shoes, thinking about life experiences and how they infiltrate the meaning of this kind of question, I think, is something she's alerting us to quite importantly. And then Alexander Kahn gives us this kind of sobering caveat. Physicians may not answer candidly for a variety of reasons. They may not tell parents what they really think for a variety of reasons that have to do with perhaps fearing the idea that you will overdetermine the decision-making process. You will influence it unduly. Here's some other, I think, very helpful distinctions from out of the literature. Now, Kahn also said this, but most recently, Dana Howard, who is a postdoc at NIH in the Bioethics Center, gave a talk recently at Vanderbilt in which she said, you know, there's plenty of evidence to suggest that doctors may not accurately predict what they would do if they were in the shoes of the parents. And there's actually quite a lot of research which suggests that we are poor predictors of how we will respond in advance of being in the context and understanding what it feels like and how we think in that context. Jody Halpern, who's written one of the very fine books on empathy, says this is extremely important, and I want to come back to this later, but she's just marking this out as an extraordinary component of what it is like to be in the context of trying to respond appropriately. And then Quist says, okay, the question will create an opportunity for intimacy and bonding. Well, we hope so. But yes, the opportunity is there, surely. And then Lainey Ross says, I wonder if the parents may be probing for a kind of a bias. That is, it's like asking, would you follow the advice you are now giving me? And then back to the Mannix piece, she says near the end of her very fine article, she says parents are asking doctors to care about the outcome as much as they do. I want you to care about this as much as I do. So I'm going to ask it in such a way that will hopefully elicit that kind of response. Thinking about this as an interpretive task, you might ask, what is the parent really asking? Where really is in quotes here, because that in itself may be questionable. For example, Mannix says, thinking one can interpret the question correctly can itself be just as paternalistic as simply answering it. And yet, thinking that the question needs no interpretation can also be paternalistic. In other words, we're never out of the interpretive grid, it seems to me. Even taking the question at what you might think of as face value, asking for a response is in itself a kind of interpretive stance, which needs then to be examined in terms of the values embedded in it. One of the nice things about Alex Kahn's recent piece, not so recent now, but the 2006 piece he wrote, he said, I think parents may be asking three kinds of things. They may be asking, I'm overwhelmed by the details and I really need to know what's going to give my child the best chance of getting better. In other words, you've inundated me with lab values and statistics, and I don't know what the hell you're saying. So my way to try to get at that is to say, what would you do? He says, or they may also be asking, or alternatively asking, see, that's interesting. You could be asking several of these questions, not just one of them, right? Am I making the right choice? I have a choice, but I'm not absolutely confident about it, and I want to see if you can validate it. Or thirdly, I'm unwilling to choose or unable to choose. Would you please do so? Old style paternalism, right? And so he gives what he thinks is the appropriate response in each of these interpretations. The first is, what will give my child the best chance? He says, you're then required to name the best option and to try to give the reasons for that option, to try to make it transparent why this option is the preferable option in terms of giving your child the best chance of surviving or improving or whatever the issue is. If they're asking, if you think they're asking, am I making the right choice? He says the role of a clinician is always to be reassuring, saying things like, it's natural to be uncertain. Everybody would have a hard time with a choice like this. And then to be supportive of the choice they make, even if you would choose differently for yourself. And then thirdly, would you please choose for me? I can't or don't want to. It's just not something I can do. I can't make this choice. If you think this is what the parents are asking, you should decline. And steer the conversation to a reflective process for considering the options. Now here's some additional considerations that occur to me, and I'm sure to you also, that are worth thinking about. That is, all recommending, all advising is situation specific, patient specific, and relationship specific, which is meant to signal a kind of a distrust of generic answers. And even the typology of Kahn, as helpful as I think it is for getting us launched into the question, you might want to say, well, surely that isn't the full typology. Because if you think that every situation actually is unique because people are distinct and unique themselves, then the question about what is being asked needs to be filtered through these kind of factors. Now you might say situation specific, sure, patient specific, sure, but why is it relationship specific? Because actually it's a clinician and a set of parents. But those relationships can differ too, even retaining their character of clinician and patient. They may have really important moral nuances that we can talk about in a few minutes. But anyway, I think this is an additional consideration to kind of keep in mind as we're working through this. The second point here, for physicians, recommending is inevitably fiduciary. And I just want to underline the trust element here. Yes, asymmetries of power and knowledge, and yes, assumptions of benevolence. We would never go see a physician if we didn't think she or he had our best interest in mind. So the trust element never goes away. It can be greater or lesser, but you're never without it, I think. So it seems to me that's an ingredient we need to filter into how to interpret this question about what would you do if this were your child. And I'm saying here trustworthiness is inevitably both professional and personal. Now, this may be contentious, but here's what I mean. I had a hard time trying to think of a situation in which I would want to say a very trustworthy physician, but not a trustworthy personal life, not a trustworthy person. Now, I might say the opposite. I might say a really trustworthy person, but not so trustworthy as a professional, right? In which I might mean something like not especially well trained, doesn't keep up with the literature, doesn't pay enough attention to his practice, etc. But going the other direction I find more difficult. It might be something to think about, but if trustworthiness is in fact vested both in the professional role and also in the person who's occupying the professional role, I think it may not be quite so easy to separate out the professional advice giving from the personal stance that the clinician might have toward this question. So if we are, or strive to be, at least in most of our professional lives, whole people, it's another way of emphasizing this point. So some additional caveats. All recommending assumes the place of a choice in a narrative or in the flow of several narratives, not all of which we can be explicit about or even aware of. So this slide is my bow to agnosticism. Others have residues of opacity. Well, probably only a philosopher would say something like that. What I mean is other people always have a residue of mystery to them, to us. What in classical philosophy terms is called the problem of other minds. And I think we might all accept that. We can never really know anybody so thoroughly that we can be in their shoes, much as we might strive to do that through empathetic engagement. But here's the worst feature, at least in terms of our confidence about these things. We are mysteries not altogether transparent even to ourselves. René Descartes was the person who in modern philosophy said, I can know my own mind. I may not know or trust the evidence of my senses, the external world, but I know I can know my own mind. That's the one thing I'm going to rest all this on. So this was the beginning of modern epistemology, that we have some kind of transparent window into ourselves. So the epistemic status of self-knowledge is thought to be something really important, traditionally speaking. But it doesn't seem to be so. You may have to take this as an article of faith for the moment, but we can argue about this if you like. But the degree to which we can't predict how we would respond in situations is perhaps one piece of evidence for this. And the idea that we surprise ourselves, and the fact that we are moving targets, actually changing over time in history with experience. This is kind of the thread of the Mannix article. She says, I'm different now than I was as a second-year resident, and was surprised to hear myself saying to the oncologist, right? Doc, what would you do if you were the patient? So if this is true, this means our most cherished values may require probing and unearthing in a deliberative dialogue with those near and far, living and dead. This idea that the way to some kind of robust notion of knowledge that you can feel reasonably confident about always comes about through an exchange, not through introspection, not through necessarily imagining yourself in a context, but through talking back and forth and worrying and rethinking and writing and then rethinking and retalking with a wide range of people. And my last little caveat here, decisions can turn. A decision that a family can make can turn on unpredictable, individualized moral features. So several years ago, I was a consent monitor for an experimental procedure which had to do with closing the back of spina bifida fetuses as a way of controlling the hydrodynamics in the spinal column in the brain, thought to be beneficial. If we can sew the back up prior to birth, we may be able to avoid some of the developmental problems that kids with spina bifida have. And so we were doing this as an experimental protocol. I was the consent monitor and spent a fair amount of time then with the couples who were considering this surgery. One couple had a very difficult time trying to figure out what to do. And over a 2-day process, they called late one evening and said, "We want the surgery." And I said, "Well, what is it that was the determining factor in your decision?" It turns out that the hotel in which they were staying as they were visiting the large medical center where this was being offered, the hotel was on a street called Mount Moriah Road. They hadn't noticed that before. They noticed it. They went back to the hotel room, opened the Gideon Bible, and read the passage about Abraham taking Isaac to be sacrificed, and then the ram is found in the bushes, and Isaac survives, and they took this as a portent to them about what they should be doing here. So I'm telling this story just as an illustration of what an unpredictable thing it can be to try to figure out what is really important to another person in making sense of the situation that they are in and the decision they have to take. So now I want to switch just a little and talk about a recommendation, the idea of a clinician making a recommendation. I think it's helpful to think about a recommendation as part of a valid informed consent process. If you take the aim of informed consent being enablement of the patient or the surrogate decision maker to deliberate effectively. So enabling an effective deliberation requires a lot of interpretation by the clinicians on hand. My assumption is that patients and families rarely know what to make of medical data without a recommendation. It's certainly been my experience when I was a patient, my children were a patient, or my parents were patients. And data, not just values, need to be interpreted. Science as applied to individuals is already an interpretation. So I'm suggesting that many of the hazards of explaining value judgments that may be embedded in a recommendation are also present in explaining the science behind the data and where the data leads. And here's Catherine Montgomery in her wonderful book, What Doctors Think, underlining this point. Even with the last molecular function understood, the genome fully explicated, cancer curable, the care of sick people will not be an unmediated, quote, application of science. The attentive focus on the particular patient that is a clinician's moral obligation will continue to compel the exercise of practical reason. So if you think about this as the clinical epistemology, the moral epistemology is very similar. The same kind of judgments with uncertainty about application of core principles, with the unpredictable distribution of diverse values within patients' moral sensibility, the way each option will figure into the good for the lives of patients and families, these same kind of judgments are evident in ethics as they are in science. So I'm suggesting perhaps this is a question, what would you do, Doc, if this were your child that is different, not in kind, but simply in degree? I think it becomes more difficult when there is no recommendation, when there is no clear explanation of the thinking behind a recommendation, and in those cases in which the deliberative process that you want to have happen is compromised in some way. In this sense, I think bioethics has done us a disservice in its hyper-emphasis upon autonomy. And I see this most frequently actually in the residents that I've worked with, in which the paradigm is we just present the choices and the patient or the family make the decision. And we're trying very hard not to be paternalistic, not to sway or influence the decision, because we've also been taught that the way we frame and phrase may have an impact. So we're hypersensitive to that. But sometimes, perhaps more often than not, we are also doing a disservice to patients and their families because they're not sure what to make of what the clinicians are telling them. So this is not an argument for old-style paternalism. This is an argument about a more fulsome engagement. If we want shared decision-making, then I think a recommendation almost always has to be a part of that. But beyond that, not so much the decision, but the framing of it, and the framing of a compassionate recommendation or expectation. Every clinician, I think, knows this, but it's worth emphasizing. Recognizing and naming the parental virtues in these really wrenching situations. Things like, you've shown great courage here, or I admire the way you have sustained hope, or I've noticed that you have been here in the nursery almost every day, and I know that must be difficult for you. So affirming the decision maker, not just the decision. If we stop focusing so much on the decision and talking about the decision maker, the reason to recognize and name the virtues that you can see is because it will elicit the best in those parents or that family. Because we want to live up to the kind of virtues that people see in us. And more controversially, I would say offering a blessing is sometimes a good idea. Not always. You have to be a little more careful with this. But even among agnostics and skeptics, I think the term God is just a nickname, actually. It's a metaphor for whatever people consider sacred in life. And the gesture, I think, works even when there is no particular theological content attached to it. There's a wonderful story about the physicist Niels Bohr, who had a good luck horseshoe hanging in his office. And one of his colleagues came in and said, Niels, what are you doing with that good luck horseshoe on your wall? Surely you don't think that brings you good luck. And he said, no, of course not, but I understand it works whether you believe in it or not. And I think in the same vein, what I'm suggesting here is a blessing works as a gesture of human connection and an offer of human well-being even when there isn't any particular theological backing. Okay. This is a rufous-sided tui, and he feeds in my yard. This is the male of the species. They're ground feeders. They're just wonderfully beautiful birds. So we're close. I emphasize trust because I think trustworthiness is just so fundamental to relationships between clinicians and the people they're trying to help. This is my favorite way of talking about how important this is. Agios ophelein taus alguntas. It is the masthead on the masthead of the Pharos, which is the official publication of AOA, which, as you know, is the Phi Beta Kappa of medicine. Worthy to serve the suffering, meaning trustworthy, fundamentally. So if I were listing virtues, these are the ones I think are extraordinarily important in being a trustworthy person in terms of recommending and advising and relating. We can come back and talk about any of these that are particularly interesting to you. And it's just a partial list, of course. Now, the reason for trying to emphasize the virtues just a little is that, again, bioethics has made us so focused on principles. Autonomy, beneficence, non-maleficence, justice. We forget that the personal enactment of ethics really has to do with the practice and exercise of traits of character. So it's a way of kind of highlighting this again. And we could go back, if you like, and talk about any of these in particular. Let me talk about two that may be particularly salient for the question we're dealing with today. Churchill is a palliative care doc in Canada. Nothing promotes humility more effectively than the growing realization that little separates us from our patients. Again, this is the story of Rebecca Maddox, finding herself asking the same question that was posed to her. And Charles Bosk, really one of the classics, I think, of bioethics and medical sociology. Humility works by opening us to recognition of mistakes and to forgiveness, which permits survival in the faces of mistakes. This was a book, as you likely know, about mistakes in surgery, but I think it applies to medicine more generally. And then hope. The reason to focus on this is because hope is so misunderstood, and we keep talking about the worry of taking away hope from patients, or squelching their hope. Another really lovely recent book, Judith Andre's Worldly Virtue. She says we have to distinguish, she was not the first to do this, but she does such a nice job with it. We have to distinguish between optimism, which is, she says, the U.S. state ideology, a compulsive chair in this idea that what I fervently want will happen, which I think in medicine sometimes takes the form of magical thinking. I really want this so desperately, and surely the world is not so cruel that I will be denied this, that my child will survive. And the opposite is the fear that the world is cruel, deeply unjust. Hope, open hope, she calls it, realism about the facts, yet openness to the idea that something good as yet unimagined can emerge. It doesn't necessarily have a particular endpoint that is hoped for. It's really just a stance of being open to an undisclosed goodness. And the opposite is despair. So that's what I have for you. I thank you for your questions, your comments, also from your objections and rebuttals, because that's where the learning is for me. Thanks.
Thank you for the talk. And just to let our studio audience know, a lot of times, and our online audience, a lot of times people come here and give talks that they'd given other places, but this you just witnessed is a world premiere of this talk.
All too obvious, I fear.
Well, and for the people online, if you have questions or comments, that little chat box in the lower right-hand corner of your screen, type those in and we will read them out. Let me start the discussion by saying I tried really hard to follow the talk and I took a lot of notes, but I'm not sure you answered the question. How should we respond when a doc says, what would you do if it was your child? Or maybe the response was in this vague notion of blessing. But is that, maybe say a little bit more about what that might mean?
Well, I think what I wanted to signal is the idea that, one, the interpretive task is an incredibly important one. Two, I would distrust pat answers to the question because I think it can admit to a wide range some of which were on display and which these reflective pediatricians have offered up to us. Those make a lot of sense to me. But I'm trying also to emphasize the contextual nature of anything that would count like a meaningful response. And trying to highlight the features that I think are just as important as the answer that is given, which is the framing of the recommendation or the response that's given to this question, based on a certain set of assumptions about how do you enable people who are in crisis, as these parents almost always are, how do you enable them to use the resources that they have brought to this situation? And this is what I meant by recognizing and naming the virtues that they themselves have put on exhibit during the long process of trying to sort this out. And the blessing is kind of like saying, I honor you as a person. I want the best for you in this, which I think is just an extension of the clinician's obligation of benevolence, generally speaking.
Great, thanks.
I have a question, sir. I too am wondering if you've answered the question that you set out in your title. And I'm going to go a different direction by noting that the question specifies or presumes a pediatric context. Doctor, what would you do if this were your child? Of course, there's an analog in adult bioethics. Doctor, what would you do if you were me? And I didn't hear anything specific in your account that would set the pediatric context as unique and of a different kind fundamentally than the adult context. So I'm wondering if you would answer those two questions in any interestingly different ways. And I'm wondering both for its own sake, I mean, even us here at the Children's Mercy Bioethics Center think adult bioethics is important. Not as important as pediatric bioethics, but it's still important. But also because I think that it helps clarify this, idea of, is there anything ethically unique about the pediatric context, and specifically about giving an answer or a recommendation to a parent as opposed to a person who is presumably an autonomous individual,
Yes.
capable of interrogating you on behalf of their own interests, and discarding your reasoning, whereas the child may be in a different position as a vulnerable agent for whom decisions are being made without necessarily any of their input or
Right.
Such. So just kind of wondering if you would give any different ethical advice on answering the adult question or the pediatric question.
Well, I'm hearing the voice of Ellen Wright Clayton, my pediatrics colleague at Vanderbilt right now, saying, yes, of course they're different. And it's because you're always making a decision for somebody else. You're always in a proxy situation. And I think that's right. I think it is more precarious to try to arrive at a judgment about another person. I have not had that experience myself in terms of a really severe critical decision about any of my children, but I have with regard to my parents. And I know the angst that goes into that. And I know how deeply one has to try to draw upon all the kind of history you have with that person. So yes, I think they are different. There are more wrinkles in a proxy decision context. But it seems to me a little bit easier if it's me and I'm wondering what to do, and I'm asking, what would you do, Doc? One, I would only ask that question for physicians whose opinions I really want, right? And that isn't all of them, of course. And from physicians I know are reflective in this way and willing to talk for a while about it. Because then I would expect another question back at me about, tell me the things that are important to you. Let's go over again the things that you're hoping for out of option A or option B, which is a way of trying to check the register in the patient's head of the kind of things they've been told. But sometimes it is really just asking for a recommendation. I mean, you've laid these out, and I really want to know, what do you think is the best option? I'm almost never asking this question, if it's me, as a way of trying to say, I want to know what you would do given who you are. It's always, I want to know what you would do to the extent that you can get inside my skin and empathize with the kind of goals and ideals and the cost-benefit calculus I'm doing. But it seems to me that's much easier to do if it's me. If it's another person, it just becomes more complicated. It has to be filtered through this layer of, how much do I really know? And what would they choose for themselves? And what is really medically best? And am I in too much of a hurry about this? And on, a whole range of things which wouldn't occur to me with nearly the same degree of acuity if it were just me. So yes, I think it's really different.
So the way you describe that hypothetical interaction, do you have a question too? Okay. The way you describe that hypothetical interaction, if you asked your doctor that, it seems to me has to do with your contrast of trust and trustworthiness. As a patient, it seems in that hypothetical scenario you just played out, are testing your doctor's trustworthiness. You are saying, when I ask that, I would expect him or her to come back with X, Y, or Z. And if they came back, that might show the sort of trustworthiness that you are looking for that would allow you to put your trust in them. But it also seemed like if they didn't, if they said, oh, if I was you, I'd do X, you would lose trust.
Well, it all depends on what it is.
Okay.
Right? If it's a question about which particular cataract surgery to have, it may not be nearly as important as whether or not I have kidney failure, and given my other limitation, should I choose dialysis? I mean, so yes, the weight of the decision has an awful lot to do with the interpretive hoops I want for this. If that makes any sense.
Terry, do we have some questions coming in online? Okay. Remember, people want to write in questions, type them into the chat box. We'll get to them in a minute.
Yes, I was surprised to hear you say that to conclude your response by saying that yes, the pediatric and adult world are very, very different in this regard, because it sounded to me like in regard to this question in particular, they really aren't. The context is more complicated because in peds, you're one step removed from the patient, him or herself. And the interpretive task then is that much more complicated. But, and this is following up a little bit on what you were saying, Dr. Lantos, it sounds like you put a whole lot of weight in the person of the responder. You're doing a virtue ethics, and the virtue is in the virtue of the physician who was asked to respond, which would be the same in the adult physician or the pediatric physician, wouldn't it?
Yes. So you're making an excellent point here. I'm not saying they're radically different. I'm just saying that the difference for deciding for somebody else is so weighty that I want to separate those out. But yes, I think the interpretive task is pretty much the same. It's just more complicated in the pediatrics.
And bottom line, what really counts is the virtue of the respondent.
I think a lot of times that's what's being probed. Is this a person I can trust? And trust is, I think, a kind of an element in many of the kind of responses that our pediatric commentators have given. And I just wanted to kind of flesh that out because I think it's, as I say, I think it's inexpugnable. You just can't beat it out of the situation. You can't remove it and get rid of it. There's always an element there that has to do with trustworthiness. I think it's the most fundamental thing that anybody who's a professional helper ever has to do, is to establish yourself as trustworthy. If you can do that, you can do many, many things. If you can't do that, you're dead.
Figuratively speaking. Go ahead.
We have a few questions rolling in online, but let me start with a question that came via Twitter. Someone is asking, how do you know, or how could you know, which of Khan's questions the family is actually asking? So is there any sort of advice about how to initiate or engage in the deliberative, interpretive process, figuring out any rules of thumb even?
Yeah, well, I've sold Alex Khan short, as I have each of the people I've just put snippets up on, because in his article, which is really such a nice piece of work, he gives you examples about the next question he asks, or how he tries to probe something, how he tries to figure out which of these three alternatives in his experience have been the most prominent, which one is being asked here. So those are really worth a careful read. And it is the kind of probing you might imagine. Tell me a little bit more, or I'm not sure what you're asking. Is it this, or is it that? Said in such a way that it invites a response. It's an opening. So, let me just add one more thing. We focus, I think, so much on getting the words right that we forget that the demeanor, people's bodily demeanor, is in itself a very meaningful gesture, and we're signaling in all kinds of ways, yes, I want to know more. Some clever social scientist has actually done a study of this and says, if you end an interview with a patient and say, got any questions? The patient knows that you're done. If you say, you probably have some questions and I'd like to hear what they are, it just makes a world of difference. And especially if you're not getting up and have your door on the hand on the door handle and you're leaning forward and all those other kind of things. But so if the spoken word is simply another kind of bodily gesture, this is Maurice Merleau-Ponty, right? Another kind of gesture that we're putting out there, which carries its own significations, then I think we're more likely to be on solid ground here. And then maybe the precise wording won't be so important.
And that is a two-way conversation of physical and verbal gesture. So it's the patient's body language or the parent's body language as well.
Yes.
They ask.
Yes.
Okay, we've got some questions online. I'm not sure, there's one continued on here. Can you tell me which question that was for? Is that for the first one, second one, or third one? I'm asking our technical supporter here. Just want to make sure I get it to the right
While
one.
we're waiting, if you want to tweet a question in, it's at hashtag what would you do, doc?
Okay, so the first question from our online participants asks, between my wife and I, she struggles more understanding data and implications and is far more likely to ask the what would you do question, and has. How do you help close that knowledge and understanding gap of the data and, more importantly, implications?
That's a John Lantos question.
Well, it makes me think of some click and clack episodes where it turns out to be not about the car, but about the marriage.
About the marriage, yeah.
Yeah. But I don't think closing the gap is the point. I'm not sure if it was a health professional writing the question, but if so, and the wife is not a health professional, then the wife would be the more typical patient. And I don't think what we're trying to do is close the knowledge gap and educate our patients to know what health professionals know. What we're trying to do is figure out what exactly they're asking when they ask the "what would you do" question, which is
if I so dare, I think my interpretation of the question is they're asking, I think, how to better present data and relevant implications in the first place in a way that makes it easier for people to not be overwhelmed by it. How do you decide between the right amount of and the right kind of data to present and the right way to frame it such that you don't overwhelm someone in the first place and get to the point where they're asking this question because they feel like that's the only way they can make a decision is to have you cut to the chase.
Let us know if we got it
and
right.
If I got that wrong, please do respond and clarify.
And I thought your point, Larry, about how the data also is always inevitably interpreted is part of the answer here. That is, there is no neutral, objective, value-free way of presenting data, whether it's framing issues or body language or what have you. So I think the question may not be how to better present it, as in make the data more clearer. Instead, I think it may be what ways are you presenting it that prevent a person from being able to arrive at a decision? Angie, first.
I was just going to weigh in on that. Is that it may not be the numbers that are bothering the person. They want what you've been talking about, is that to slow down and stop and talk and have that relationship with the person if they're not a health professional, because our world is so fast paced. You go in and out. The doc has 10 minutes to see you. That maybe, yes, the data is part of the issue because they want to understand it, but they also want somebody to stop and listen and allow them that trustworthiness, that you're going to provide them that meaning to the data beyond the numbers. So I was just, I think that's sometimes what people need.
Well, it's very interesting, the whole phenomenon of being heard, when people feel that they have been heard. And it doesn't have as much to do with clock time as it has to do with a sense that the clinician is present, really present, attentive. And there are lots of interesting ways of trying to do that, trying to make up for the fact that there is never quite enough time for some patients. But yeah, I mean, the whole question about sometimes it really is the data. I don't understand what you're saying, but sometimes it's like I haven't really had a hearing yet, and that's what I'm asking for.
Sarosh, go ahead.
Okay, so in some cases we see that there are situations like we often hear parents saying that we want everything done, and clinicians sometimes feel that it's futile care or unnecessary care that's being given to babies. In such a situation, if parents ask this question, you think being more directive than facilitative in their approach is better in that case? Because if the clinician's conscience says that such a care is futile for the baby, you think being directive in such counseling is better?
Well, the term futility, of course, has a long and checkered history, and I don't want to get sidetracked into that, but setting the table in the right way. Now, my instance here is the intensive care units. One of the things we've tried to study at Vanderbilt is, would it help if you set expectations earlier in the process? Let's say within the first 24 hours in which a patient is admitted to an ICU, as opposed to waiting until there is a crisis point. Being part of that's being consistent. Part of it is also just being sort of very, very candid. So one of the most effective introductions to this that I've heard began like this. Your dad, maybe your child, is in the ICU, and it's only people who are extraordinarily sick who are in the ICU, and you need to know that they may die. we're going to do everything we can, or maybe you say we're going to do everything that it's reasonable to do to help, the patient get better. But you've laid out a set of expectations which cover, a variety of outcomes. It isn't always necessarily hopeful in the sense of a good outcome, but a kind of realism. And the people who have talked to me about this are people I really trust because they learned it the hard way. From being too optimistic too soon, not talking quite enough or thoroughly enough about the range of things that could happen. Does that help in response to your question? Yeah. Mentioning the word death early on, if in fact that is a real possibility.
Well, and it does build trustworthiness too, because I don't think anybody who has a loved one admitted to an ICU isn't thinking that they might die. So it's just taking what's in everybody's mind and putting it out there on the table to say, this is something we have to keep in mind. Go ahead.
Several questions left and only 5 minutes, so this is going to be the speed round here. Would you recommend something different for your patient from what you would recommend for your own child? I mean, or what's the ethics of ever giving something different to a parent? Yeah, leave it at that.
Well,
normally you would recommend only the best for your child, so how could you recommend anything but the best for someone else's child?
Although the best may be to remove the respirator. So, I mean, yes, I can conceive of a situation in which I think, in the clinician's judgment, what is really best for this family is not what I would recommend for my own child. And that's why trying to respect this sort of value pluralism is so important. At the same time, I'm back to my theme that I think patients and their families always do better when there is a recommendation, even if the parents don't take it, but offered up in such a way that it can be refused, it can be turned down without raising too many questions.
The answer to that question in speed round is sometimes.
Well,
it depends.
Sometimes, but let's let John Lantos, because
sometimes is yes.
Yes.
Would you
Yes.
ever was the question.
Yeah.
Sometimes is yes.
Yes.
Absolutely. I mean,
Yeah. No, I agree
for
too.
the same reasons.
Next question. I suggest parents, especially in the NICU setting, do not usually have the benefit of a relationship of trust with the physician, given the circumstances of arrival and how long, not having met them before. It's my experience when a parent is asking, "What would you do, doc?" they are hoping to learn, A, if the physician has a child or children, 2, as an exercise of trustworthiness, and 3, for me in particular, the participant says, to make a human connection with the physician and test my spiritual sense of whether or not I should trust the doctor. If I can discern that the physician has a child, my hopes are the doctor can empathize with me, us, in a way that hopefully makes my child more than a patient. May not make sense, but it's certainly a dynamic I've seen play out in the NICU.
Makes perfect sense, and I could only say thank you very much for that comment.
Okay. And then the next question says, although I think I can understand your discussion regarding blessings, I wonder for those that truly have a deep faith, if this would potentially come across as disingenuous.
I would think it all depends, as I've said before, on how you do it. I mean, if you're offering up something that has a kind of a theological guarantee to it, God's always going to do what's best for you, or, that old cliche, God never gives us more than we can bear up with, which I always think, my God, what kind of theology is that? But if, in fact, the blessing is a gesture of respect and good intentions, good feeling, a well-wishing to the person. So nothing too theologically complicated, I think, but something something that is recognizable, not for its content, right? But for the human gesture that it is. I care about you, basically.
Could probably do one more.
We got
quick
one more good question to end with,
Okay.
I think. The skills that you're describing are not, so far as I can tell, a component of most medical education programs. I'm concerned that many physicians simply lack either the temperament or the skill set required for the kind of engagement with the decision-making process you're describing. Do you have any suggestions for how, as clinical ethicists and educators, we can promote and encourage the development of these skills among physicians?
Well, I like the word skills a great deal because it implies it's not a God-given talent. You can learn it, you can get better at it, you can polish it by practicing. And I think it's only a matter of giving enough time and attention to that, and also saying this is
The word virtues might be better, though, huh?
well,
Because that also has the same.
in this context, skills and virtues are in fact the same.
And perhaps simulations might be a good way to do it, since it is
yes.
a skill and a virtue that
And to give a
require
virtue-based approach, watching and paying
practice.
attention to excellent role models who one can learn from. and
learning
see in
from your
different
mistakes.
contexts.
Yes.
So go out and practice. Thank you very much, everybody who attended here today. Thanks to Larry Churchill for
My pleasure.
coming on the show.
My pleasure.